Institutions Committee. This is Thursday, January 23rd. It's our 9 o'clock meeting. And this morning, we're going to spend some time talking about the MAT or MOUD program that has been put in place quite a while ago within our correctional facilities. And we have Katie McClin from Ledge Council with us, and Katie lived with us when we originally did the law. And I thought it would be really helpful for folks to understand what is in statute in terms of the delivery of the MOUD program within the facilities. We also have folks here from the Department of Health that deals directly with opioid treatment out in the community. And one thing that we were really clear about when we established the MAT program within our correctional system, we wanted it to be equal to what is provided out in the community, but we didn't want it to be more and we didn't want it to be less. And we were very, very clear about that. And I think that is still our intent. And in order for us to understand if there's going to be any proposed changes to the MAT program in our correctional facilities, we have to understand what's in place right now. So Katie, I'm going to turn it over to you and welcome.
Thank you.
And I'm sure you have some documents.
I do.
Okay.
Probably more words than you'd like. So I'm Katie McClin, Office of Legislative Counsel. As Representative Gregoire knows, I spend most of my time upstairs in House Human Services, House Healthcare, and downstairs in Senate Health and Welfare. And staff issues related to substance use disorder. And when that issue comes into a correctional setting, I try to follow the issue into this room. I have put together what I think is a summary, but when you see the words on the page, there's still plenty of words on the page. I'm still an attorney and I can't help myself. So I will pull that up for you and we can walk through it.
I think they'll work. It'll be about.
Okay.
And it's on our website.
So the language about medical care for inmates is in Title 28 of the Green Books. Has somebody talked to you about what the Green Books are when we?
Yeah, a little bit.
Okay.
It might be good to give a
Little overview. Okay. So literally the Green Books over there, they're organized by subject. That is where all of this Vermont state laws live in printed form. You also can find them on the website, but that's the official version. The subjects are assigned a number, and corrections has number 28. So if you were to pull book 28 off the shelf, that would sort of bring you to the right place. Those books are divided into chapters, and the chapters are subjects within each of the titles. So we're working today in Title 28, Chapter 11. I'm hesitating whether I should also point out that we have white books. So these white books are, each one of those books is a year of worth of acts that the General Assembly passed. So if you're ever wanting to see everything that passed in 2023, you grab the 2023 book off the shelf, and it's ordered numerically by act number. So it's not organized by topic the way the Green Books are. That's just a numerical listing of the order the acts passed, and you can see the act from the beginning of the act to the end. Whereas the Green Books, if you're making changes and in multiple subject areas, multiple titles, the language from the act is sort of distributed across the Green Books by subject.
So the act, and if you remember, folks, I said, when a bill is a bill, goes through the legislative process. When it goes to the governor's office to be signed, the minute it gets signed into law, it becomes an act. And the number of the act is sequential based on the first, whatever bill gets to the governor first this year, this biennium, this session, and signs that very first bill, that will be Act 1. And the second bill will be Act 2. So it goes all the way up. So we're working in one bill, Act 69, that was the 69th one. Or if it goes to 182, 182nd bill that became law. That's how the act numbers are calculated.
So what I've brought for you today are two sections that are pulled out of Title 28, Chapter 11, that deal with substance use disorder in a correctional setting. The first section is entitled Medical Care of Inmates. It is broader than just substance use disorder, but even some of the provisions that are not specific to substance use disorder may still be influential or affect how substance use disorder is provided in a correctional setting. So I've brought you all of that language, and I've tried to italicize language that is actually specific to substance use disorder. So you'll see that. And then the second section I've brought you is all italicized because this actually has to do with medication for opioid use disorder in a correctional facility. So this is, the second section is exactly on target of what you're speaking about today.
So Katie, can you go back? I don't want to interrupt, but I am going to interrupt. I think it's really important for the committee to see that very first sentence in A, provision of medical care. That's the starting point for any medical care within DOC, within our facilities. It is required to provide health care for inmates in accordance with prevailing medical standards. Now, there's really no definition of prevailing medical standards, correct?
Not here. We do sometimes talk about medical necessity, and that is defined, but not prevailing medical standard.
So that's the foundation of medical care that's provided to our folks who are incarcerated. And I think that's really important to understand that as our starting point. Am I off base on that, Katie? I mean, I think it's, let's see. It does. So could you go through what screening and assessment is?
Go through both of the sections. Before I did what you sort of alluded to earlier, we used to call the treatment associated with opioid use disorder medication assisted treatment. And as the language in Title 28 tries to reflect what is in Title 18, the health around treatment for opioid use disorder, that terminology, MAT, medication assisted treatment, was updated in Title 18 to be medication for opioid use disorder. So a conforming change was made in Title 28 to reflect what was happening in the community. So you'll see MOUD, medication for opioid use disorder. Okay, so we've sort of looked at this first sentence in subsection A. It goes on to say that if receiving the standard of care means that an inmate has to leave a correctional facility, then DOC has to provide safeguards if necessary to make this happen, and for the custody of the person while confined in the medical facility. So if the best and the standard care of treatment is to be taken outside of the correctional facility, DOC will transport a patient to ensure they're receiving that standard of medical care. Screening and assessments. Once an inmate is admitted to a correctional facility, for a minimum of 14 consecutive days, the inmate must be given a physical assessment unless there are circumstances why that can't happen. Specific to what we're discussing today, an inmate is screened for substance use disorder within 24 hours of admission to a correctional facility as part of the initial and ongoing screening and assessment process, which includes screening for opioid use disorder. Then we go into emergency care. If it's believed that the inmate needs medical care, officers and employees shall provide emergency first aid and immediately secure additional medical care. Correctional facilities shall have at least one person on staff who has the emergency first aid training. Subsection D requires.
Okay, so I think there's going to be questions that pop in here, Katie.
Slow down.
I just have a question. It mentions in there, Methadone, that's something they would have to be transported out of the facility to continue, or is this implying that they can continue methadone treatment within the
It would
facility?
have to be a hub. So to the extent there could be a hub at a correctional facility, then it could be received there. Otherwise, it would have to be a transport outside. And I'm not sure at this point if we have any hubs in a correctional facility.
You know, and we can talk with,
The easy answer to the question is we bring methadone into the facilities. So for anybody who's on methadone or needs methadone, we bring it into the facilities and it's stored there for the patient who needs it while they're incarcerated.
Interesting. They do bring it up.
Yes.
Oh,
Tommy, could you identify yourself for the
Oh,
record?
my apologies to the record, Tony Fallon. I'm work for the Department of Health Division of Substance Use Services.
Tony was so instrumental in when we were doing the law on MAT. We really worked with Tony to help us figure out how we deliver MAT within our correction facilities. Tony lived in the committee because we wanted to make sure it was like it was on the outside. But there's some high bars to become a HUD and a hub. And there's so much security issues within corrections, it's really difficult to meet that standard.
I am confused now.
Mhm.
None of our facilities are hubs or HUDs,
Hubs.
and yet we still bring methadone in, so I don't know.
Well, let's work through the law here first, okay? We kind of jumped a little bit.
Okay, so subsection D is directs DOC to establish, maintain policies for delivery of healthcare in accordance with the policies set out in subsection A. And then in subsection E, we have language about how we deal with individuals who come into a correctional setting who have a pre-existing prescription. So unless otherwise provided, an inmate who's admitted to a correctional facility while under the care of a licensed physician, physician assistant, or APRN, and who is taking medication at the time of admission pursuant to a valid prescription.
This is any medication.
Yep.
Could be heart, could be insulin, blood pressure, any medication that the person's on.
And then we have a list of how the validity of a prescription is verified. And this goes on to say, including buprenorphine, methadone, or other MOUD medication, that individual is entitled to continue that medication and to be provided that medication by DOC pending evaluation by a licensed physician, a PA, a physician's assistant, or an APRN.
And that would be done with our WellPath contractor.
And then in subdivision 2, we say, notwithstanding the previous subdivision, DOC may defer the provision of a validly prescribed medication if, in the clinical judgment of that professional who has done the assessment, it's not medically necessary to continue the medication at that time.
But that allows DOC to maybe substitute the brand or the type of medication, but also that medication needs to address the underlying health issue as well. And that's where there was always some confusion with folks who became incarcerated with their and family members. Well, they were on X and corrections changed it to Y. And they had no right to do that. So that's what we wanted to address here is the person comes in with a valid prescription from their provider, and WellPath will work with that prescription. And sometimes they may not carry that specific brand of medication. They may carry another type that addresses the same underlying health issue, so they can use that other type. Brian?
This is sort of about my ignorance of these drugs, but could you not then switch bupe for methadone if that's an issue?
Yeah, that's where we're gonna get in with
Okay.
Tony to talk.
And there's language in the next section about which medication somebody is inducted on and how to change.
So I just want the committee to understand this section here doesn't just deal with MAT. It deals with all medication that folks are under while they're incarcerated, based on when they come in and also based on their time of incarceration. Sometimes they will develop health issues while they're incarcerated. And this law comes into play. So it's not just substance use disorder. It's for all medication.
So in subdivision 3, we're at the point where possibly somebody had come in on a valid prescription, the provider has seen them, doesn't think that that medication is medically necessary, so they are discontinuing the medication. So if that decision about discontinuance has been made, the practitioner has to name that specific reason for discontinuance to be entered into the inmate's medical record. And then they have to provide a specific explanation to the inmate, both orally and in writing, about that change, and also provide notice to the inmate that they have the right to have their community provider notified that that discontinuance has occurred. And if I'll scroll down, but if the inmate does provide written consent to have their community provider notified, then DOC will go through with that notification to the community provider that the medication has been discontinued. And subdivision 4 says that
This is really important to pay attention to.
the General Assembly does not intend to create a new or additional private right of action in this section.
I meant 5.
Okay.
Sorry.
Subsection 5, yes, subsection 5 is important. So we have our definition section. I might do B first and then come back up to A. So B is our definition of medication for opioid use disorder. I think it's noteworthy that we are cross-referencing the definition that's in the health title. So we're using the same definition that's used in the community, which is the use of FDA-approved medications in combination with counseling and behavioral therapies to provide a whole patient approach to treatment of substance use disorder. So when we say medication for opioid use disorder, we're not literally just referring to the tablet or whatever form it's in. We're also talking about the therapy and the counseling that pairs with that medication. That is how it's defined in Title 18.
So Will, you have a question?
So I know we said that subsection 4 wasn't important, but could you explain what that means exactly?
It doesn't create an opportunity for a private lawsuit. This section does not.
Oh, that's all.
Yeah. And then subdivision 5A, medically necessary. You'll see, I think particularly in the next section, that we refer to medical necessity, making decisions based on medical necessity. And when this piece of legislation was first crafted, there was an awful lot of time put into deciding what the definition of medical necessity should be. So at that time, the General Assembly landed on the following. It describes healthcare services that are appropriate in terms of type, amount, frequency, level, setting, and duration to individuals' diagnosis or condition, are informed by generally accepted medical and scientific evidence, and are consistent with generally accepted practice parameters. Such services shall be informed by the unique needs of each individual in each presenting situation, and shall include a determination that a service is needed to achieve proper growth and development or to prevent the onset of worsening of a health condition.
So the reason I really wanted folks to understand the term medically necessary is that is used as we administer medical care to our inmates, as well as the MOUD. It has to be medically necessary for someone to be on the MOUD program. It's not at a whim. It's not at the request of the inmate. It has to be by a healthcare provider, a licensed physician, healthcare provider. It needs to be medically necessary, and it needs to meet this definition in law.
Yeah.
That makes sense to folks?
Yep.
Because that's the underlying foundation of the MAT program in our correctional facility. It's not a free-for-all and a whim.
The last subsection in this section. I believe this committee worked on this subsection last year, I think with Ben. So I had to catch up a little bit to see what changes had been made. But in subdivision 1, if an offender uses a prescribed medication while incarcerated and that medication continues to be available at the correctional facility and is clinically appropriate at the time of discharge, DOC or its contractor must provide the offender at the time of release with not less than a 28-day supply of the medication, if possible, to ensure the offender can continue taking the medication as prescribed until a new prescription can be filled in the community. DOC or its contractors must provide the exiting offender with a prescription to continue the medication after their supply at the correctional facility is depleted. What was noteworthy to me with the changes that were made last session is that this language in F1 that applies to all prescriptions, not just 28-day supply term. And the phrasing is different in the section below where it's specifically about MOUD medications. So we'll take a look at that, but I just wanted to flag that for you. In subdivision 2, this directs DOC or its contractor that it's required to identify any licensed healthcare provider or substance use treatment program or both, and to start scheduling intake appointments for the offender to assure that that person can continue care in the community as part of their reentry plan. And that DOC and its contractors may employ or contract with a caseworker or health navigator to assist with scheduling community appointments. So that is the link of DOC trying to connect the person with services as part of their reentry plan.
So at this point, I'm just going to put thought on the table for folks. You may get a call from a constituent, either about a family member or someone that they know. They just left the correctional facility. They don't have their medication. Or they're under corrections. They're in the community. They don't have their medication. The first question you should ask is, what's their status? What's their status? Are they on probation? Are they on furlough? Are they on parole? Or were they a detainee? Were they held in a facility for maybe 3 or 4 days and have been released? If they're on probation, this doesn't come into play. Because probation is set by the courts. It's not under DOC. They didn't re-enter from an incarcerated facility. It's a straight probation. So that will help you understand the situation of the person they're calling about. If they're on furlough or parole, then there's an issue there. Okay, but probation is a little different. If they were a detainee for like 3 or 4 days, there wasn't enough time for DOC to really do a reentry plan for them. So it's really important when a constituent calls and says an example about, there's a person that is under DOC or being supervised by DOC and something isn't happening. It's really important to find out what status the person is on: probation, furlough, parole, because there's different intercepts there. And this is a good example of that for the medication. Brian?
It's a question about F sub 1, but it might be more of a Tony than a Katie question. Is that?
That's
okay?
fine. It's here.
So I understand, if somebody gets out and the facility doesn't have what they need, you can't provide it. Does that happen often, and what do they do then?
So we have multiple systems of checks and balances. So this most often happens with detainees because you just don't have the lead time. So we've given when somebody's started on medication, we give them the callback number there. We will then call in a prescription to their local pharmacy paid for by the state. So they can pick up medications. If they don't have access to that, we've offered 6-day-a-week open access at the hubs. You walk in the door, we will figure it out on spot. You will be medicated. We will ensure you receive medication. And we've worked with all of the emergency departments in the state who all have approved buprenorphine protocols in the emergency departments. In the event somebody comes in the emergency department, doesn't have a prescription, just left corrections, or God forbid shows up and, it's post overdose. And so we try to make sure that we build the system of how do we catch people who may not have adequate release planning because of the circumstances with detainees.
Got it. Thank you.
Certainly.
I have a question too, and if this is too general or too big picture, just call me off and we'll talk about it another time. But Tony, can I just get a sense of like how rapidly evolving is this best practices care, and does the law keep up with it?
So I think the law is written, it's general enough that I think it does a decent job of keeping up with things. I think the nuances in it are, like, since we started medications, if we did the bill, there are now injectable forms of
Yeah.
medication. So how does that fit into the operations versus the generics of the law? But I feel like we crafted something that's pretty consistent with what we have for the community standard of medications for opioid use disorder rules that really tried to piggyback both and allowed enough flexibility in it to be able to implement well. That was really the intention.
Do you ever run into a scenario where you want to provide a treatment that you're not allowed to provide?
I think the only circumstances where we've ever kind of had those conversations, and DOC has been a fantastic partner. Things like if somebody's at high risk of diversion, but is incapable of being on methadone because of heart implications. There is no mechanism right now if somebody needed an injectable form because it's a very expensive cost. Now, there's a Medicaid waiver that will be coming into play that will allow for Medicaid to be able to pay for 90 days of treatment prior. So we could be able to use medications, injectable medication forms if we need to. And I think the only other circumstance is really, and I think it's more of a staffing. There are times where you might have an individual on methadone and they're what's called a rapid metabolizer. Normally you can take medicine once a day. It lasts for 24 hours. It works just fine. Usually lasts 36 hours. There are some folks that eat it up quickly in their own system where they may start to have symptoms 12 hours, 16 hours later, and trying to figure out how to do twice a day dosing is a challenge just based on the sheer volume of medication lines.
So I just want to be clear on F1. That pertains to all medication that's not MOUD. The 28-day supply does not pertain to MOUD. That pertains to heart, insulin. That was our intent. We were very clear about that. So maybe it needs some cleaning up,
Yeah.
but that was our intent. That 28-day supply is not MAT material. It is not. It is your heart, your cholesterol, your insulin, blood pressure. It's all of those.
I think you need a carve out to specifically say MOUD medications are carved out of F1, if that's your.
That was our intent when we did that last year. So that's a flag. I don't know how we can't lose track of that.
You can remember anything.
Yeah, but it's gonna be, we need a bill to do this.
Does 32 do that? Yeah, 32 does that. 32 does.
Oh, stop it.
No, it does. This is precisely what Eric kind of wanted to get at.
Okay.
Well, that means.
So we'll flag that. Okay.
So the next section, as you'll see by the title, medication for opioid use disorder, is specific to the use and distribution of MOUD at the correctional facility. So in subsection A, when an inmate receiving MOUD prior to entering the correctional facility continues to receive medication prescribed in the course of MOUD, the inmate shall be authorized to receive medication for as long as medically necessary. So there's that term, medically necessary, that we just looked at the definition for. It's not the first time, not the only time you'll see it in this section. So if at any time the inmate screens positive as having an opioid use disorder, So maybe they weren't initially screened as having one when they came in, but at any time when they're in a correctional facility, they're screening positive. The inmate can choose to commence buprenorphine specific MOUD if it is deemed medically necessary by a provider authorized to prescribe buprenorphine. The medication shall be available as soon as possible and for as long as medically necessary. And then to the question about what about methadone? This section does not prohibit an inmate who commences MOUD while in a correctional facility to transfer from buprenorphine to methadone if methadone is deemed medically necessary by a provider authorized to prescribe methadone and the inmate chooses to commence the methadone. So what you're seeing here is that somebody, at least under the statutory language, they're not initially starting methadone. They're commencing buprenorphine and then they could transfer to methadone per statute. I'm not sure how that happens in a correctional facility, but the statute only allows for the transfer, not for the induction on methadone.
We actually did that intentionally when we developed the law, in thinking that if you think of how medicine tends to work, you tend to start with the medication that has the better side effect and safety profiles first, all things being equal. And the reality is that buprenorphine has a better side effect and safety profile. So it was easier to administer. It was a medication that we thought would make sense. That's the normal kind of course of medication use. And had far less regulatory structures around it than did methadone. And wanted to say, let's start with this medication. In the community, it's used 2 to 1 at all. I mean, for any one person on methadone, we have 2 people on buprenorphine. So it was consistent with the community standard, consistent with what we think of as medical standards. And it was going to be quicker and easier to get the person medicated in the event that they walked in showing any symptomology. And the release plan, particularly for folks who were detainees where you didn't have time, we could get them medication much quicker if we had lots of options around buprenorphine, because we have buprenorphine prescribers in every county in the state of Vermont.
Subsection C. If this should sound familiar because it is language that's nearly identical to what we looked at in the previous section. So if the practitioner who decides to discontinue a medication, they have to cause the specific reason to be entered into the inmate's record. That explanation has to be provided to the inmate, both orally and writing, and the practitioner has to notify the inmate of the right to have their community-based provider notified of a discontinuance. So if the inmate comes in, they're screening positive for an opioid use disorder, they're already receiving MOUD in the community. And maybe the practitioner has a chance to assess the person, doesn't think the person needs to be on that medication, or it's the wrong dose, the wrong type of medication. That inmate can elect to have their community provider notified of the change or discontinuance. And if they provide a written authorization, DOC will notify. And then in subsection D, we move into language about reentry. As part of reentry planning, the department must commence MOUD prior to an inmate's release if the inmate screened positive for an opioid use disorder. Medication for opioid use disorder is medically necessary, and the inmate chooses to commence the MOUD. However, if all of these criteria are met, if MOUD is indicated and despite best efforts, induction is not possible prior to release, the department shall ensure comprehensive care coordination with a community-based provider. In subdivision 3, if an offender uses a prescribed medication for opioid use disorder while incarcerated, and that medication continues to be available at the correctional facility and is clinically appropriate at the time of discharge, the department or its contractor must provide the offender at the time of release with a legally permissible supply. That's different. A legally permissible supply. That's not 28 days. That's legally permissible. So that's going to depend on the substance, type of medication, to ensure that the offender can continue taking medication as prescribed until a new prescription can be filled in the community.
And that's what we did last year to ensure that transition to the community. They could leave the correctional facility with a 2-day supply or a 5-day supply, but it's the number of days of the supply is contingent on when the person can hook up with a hub or a spoke. So we didn't want the person to go out there with 28 days worth of MOUD medication. And that was the testimony we received last year from WellPath, from DOC with WellPath. That's what the current contract with WellPath states. That's their practice, they indicated, so we put that in statute for that. So for regular medication, it's a 28-day supply and a prescription to fill the remaining part. For an MOUD, it's only enough supplies to hold them over until they can get hooked up with a hub or a spoke. Questions, thoughts, anything?
Good.
Sean?
Just clarification, this is just me not understanding this probably. Why don't you want them to go out into the community with the MOUD?
With a 28 to
Yeah,
diversion, selling it
gotcha.
more volatile.
That's what I thought, but I just wanted clarification.
You know, it's misuse. We're handing folks a narcotic drug. Because it's still a narcotic drug that can be misused.
Yep.
In a supply that would be really hard to track, rather than let's bridge them to their next appointment so that we don't give folks more medication than what they needed.
Yep.
Which could lead to
Public safety.
Got it.
It's public safety.
Good.
And it's safety for that person as well, because if they don't go out with a supply of MOUD of some kind, the first thing they're gonna do is go out and find a fix. And that is the most volatile time when someone's re-entering for overdose.
Sure.
That's the other piece that we were trying to address.
Gotcha.
One subsection to go. I know this has been a lot of language. In subdivision E1, first, I'm going to remind you that our definition of MOUD is the medication and the counseling. So this language says that the counseling or behavioral therapy must be provided in conjunction with the use of medication for MOUD as provided by the health department's rule for medication for opioid use disorder. So that means the same rule that applies in the community for medication for opioid use disorder. Then we have language that is as part of reentry planning, DOC must inform and offer care coordination to an offender to expedite access to counseling and behavioral therapies within the community. Also, as part of reentry planning, the department or its contractor is required to identify any licensed healthcare provider or substance use disorder treatment plan program or both to schedule an intake appointment for the offender to ensure the offender can continue care in the community as part of the offender's reentry plan. DOC or its contractors may employ, contract with a caseworker, health navigator to assist with scheduling community appointments. So that's a little different than the language above, that there is authority, not a requirement, that DOC or the contractor can utilize a caseworker or health navigator to create that link with the community. So that's what you have in statute.
Discussions? Thoughts?
I have a couple just as far as like, do we have numbers as far as what the overdose rate was when people re-entered the community prior to implementing this versus what they are now, if it's actually had an impact?
It has had a decrease. We were never, so we looked a year out. And we've always had some amount of medicine in. It used to be up to 30 days, and then we moved it up to 90 days, and then we moved it out to everybody. But we have seen a decrease in post-release overdoses when you look out a year.
Okay, thank you.
Yes. And the reality is most of the overdoses for folks leaving correctional facilities who are not on medications tend to happen in the first 2 weeks. And to put into context, those individuals are at risk. Their death rate is 129 times the general population. So we're not talking that folks die infrequently, unfortunately, which was really the impetus for these people are at risk. To Chair Emmons' point earlier, the loss of tolerance happens very quickly. And the first place where you lose tolerance is in your respiratory system. So that amount that you used to use that was maintaining is now lethal. And folks come out of corrections and go, oh my goodness, I've been held off. I'm still sick because post-acute withdrawal symptoms can last up to a year. I don't feel good. I'm going to go use this. This is what my dose has been historically. And that for them now is a lethal dose. And as where if we drink, you might recognize after 2 beers, I have a buzz, versus I used to do 4. If you are using injection drugs, you have about a 5-second window before it is almost instantaneous. If you have pushed the plunger at that point in time, it is, there is no coming back at that point. It's either going to happen or not.
It can kill you that quickly.
The effect, because it crosses the blood-brain barrier within 5 seconds. So if you think of, again, the longer the drug, like you have an ability to say, oh, I had a beer, I don't have a buzz. I'm going to have a second beer. Oh, wait, I do have a buzz. This is, you have a 5-second window for full effect.
Kevin,
If there is a conflict and medically necessary, how does that get resolved?
so I'm wondering if Tony should come up and get off.
Thank you.
Thank you. Thanks.
Thank you, Kate.
So Tony, come on up, introduce yourself again for the record. I'd say Tony was our guru. We were doing this language.
Please keep expectations low. If I can tie my shoes, I'm hoping somebody will give me M&Ms.
So Kevin, ask the question again.
So for the record, Tony Folland, I work for the Department of Health Division of Substance Use, and I am the clinical services manager. And then there is a federally designated title, which is horrible, which is the State Opioid Treatment Authority, and I am an authority of nothing. But that is the federal designated title that I have to get.
So Kevin,
Thank you for having me.
your question.
So if when there is a conflict in the definition of medically necessary, how does that get resolved?
You know, we haven't had a lot of conflicts around medical necessity. We have had, and anytime there's been questions on whether to discontinue medication, the folks at WellPath, the folks at DOC almost always coordinate with us to do consultations. I think where we've seen that more often on the discontinue of medication is if somebody has been found to be potentially diverting their medication. If they're diverting their medication, it creates a public safety risk to the community, to the folks in the facility. It also then brings into question how much medicine did they need? Were they diverting it because they actually needed more medicine and they were getting more medication? Was it that they needed less medication? And so those are the times where they would often say, we're probably going to discontinue this medicine. Can we refer this individual to a hub to then do a reevaluation of would methadone, even though it has a more significant side effect and safety profile, it's a liquid. So it's much more difficult to divert than a tablet that goes under your tongue for a 3 to 5 minute period of time. There are other safety features that can be done, as well as then you've got, in the hub system, we can get all of the records from the Department of Corrections, community existing records, and most of the hubs have an addiction medicine specialty physician at the helm.
Wow. That was a lot more complex. than I
Well, that is the name of the day, unfortunately, is the complexity of how we did this, because it's an entire healthcare system.
Let me try again then. the individual who has had problems with medications in the past. The doctor says you don't need a medication
Yep.
because it's not medically necessary. They say, no, I do need it. How does that get resolved?
Usually that gets resolved by getting previous medical records and checking the Vermont prescription monitoring system. My experience has been if somebody's had these medications in the community, the WellPath providers continue to provide them. There is often breaks in care, but if there's been a justifiable history, that is sufficient for,
So a reliable track record
yes.
is assumed to continue to be reliable. Again, one more and then I'll shut up. The opposite. The individual wants to reduce, wants to get off of it.
Yeah. So we will taper individuals off during corrections. We do it very hesitantly because of the risk of, again, people who have substance use often have real impulse control concerns. They make impulsive decisions. We want to make sure that those decisions are not being done impulsively because we don't want anybody to be hurt by it. But if an individual says, yes, I do not want to be on this medication anymore, I'm going to be in this facility for X period of time, my goal is to be off it, then we will bring them off it slowly to try to minimize the amount of withdrawal symptoms they experience so they could leave without medication in their system.
But the individual needs to make that known.
The individual would need to make that known. Yes.
My experience with two sons on opioids, their provider did not encourage them to get off of Suboxone.
Right.
And now that they are free of it,
Yep.
they look back and say, I wish it had happened a long time ago. It's my quality of life
Yep.
is so much better, but they weren't encouraged to do that.
And what we've worked with providers on is basically to say, let's look at the person. Again, in retrospect, we often will say, I wish I hadn't done that. In the moment, did we keep your sons alive? And were they at a point at any given time in that process where then it made sense to start? Did they have what we would call recovery capital? But clearly they have a supportive family, but did they have the other pieces that hopefully would maintain them so that it wasn't the inadvertent, we stopped your medication prematurely?
Feel safe is where you're going.
Yes. And because the outcomes unfortunately are just all too often negative and there's no lead into it. It becomes the first potential use afterwards is potentially lethal. And how do we guard against the very worst outcome?
So we have some more questions. Troy and then Will.
Are you aware of any rumblings or known pending federal changes that we should be preparing for? Especially in policy.
Yeah. So I think there's a little bit of a wild card given the new administration and who they will have. The two newest changes I think were actually recent. One which, so historically, if somebody went to a hub, and I'll give better definitions. So if you think of a hub as a hub in general medical terms is the most restrictive monitored form of medication in the United States for outpatient medicine. It is licensed by the federal government. It is two forms of the federal government. It's licensed by SAMHSA. It's licensed by the DEA. It's certified by the state. They have to be a Medicaid provider, and then they have to also be accredited by an accreditation body.
That's why correctional facilities can't meet that.
They are widely and highly regulated. Historically, so pre-COVID, the amount of medication that somebody could receive take-home wise, not having to come in every day, 7 days a week or 6 days a week, was regulated by 8 behaviors, and some of which made sense. You know, the absence of current drug use, no evidence of recent criminal involvement, that folks had some kind of quality of life that was filling their day, whether it was employment or volunteerism or things that would give them a structure in their world. Full engagement in the clinic. So there were lots of kind of safeguards to say this is what stable looks like. But the last line was, now we're only going to let you have a finite amount of medication based on how long you've been here. So in order for somebody, no matter how stable they were, to be able to get out to 2 weeks worth of take-home medicine was 18 months. To get out to a week's worth took a year. So it was this slow, graduated process, which was helpful, could be helpful to the individual who is struggling, but for the individual who's trying to get back to work, the individual who's got to travel, the individual who really has built a quality of life, where going to the clinic every day no longer provides them a structure in their world, but is a barrier to their lives, it was a real problem. And so we'd have to go through exemptions, and the state would have to sign it. So I would get exemptions and the feds would have to sign it. And sometimes there'd be disagreement. They removed that kind of piece of time and treatment recently and said, listen, if the medical provider, as we do with any other medical care, says, I think you're safe enough to be able to have this medicine, you're able to carry it, and you're able to safely store it, we're going to give you some amount if that is what makes the most logical, meaningful sense. And that was a substantial change because it removes the opposite barrier. We're not giving out too much medicine. In this case, we were restricting it so much that it was problematic. The second significant change, I think, is for buprenorphine. Historically, again, pre-COVID, and they gave us flexibilities during COVID. Pre-COVID, they had what was called the Ryan Haight Internet Pharmacy Act, which was a DEA law. There was a young man, Ryan Haight was, I think, a 16-year-old who was able to find internet-based medications, was never evaluated by a medical provider, but got a large amount of oxycodone or OxyContin to the point that he died of an overdose. And so the DEA built in a system saying that anybody who was going to receive a narcotics prescription had to be evaluated face-to-face by a medical provider, that this over the internet thing wasn't going to work. We needed to have a safety check. And there were 2 exemptions. One was, if you're sitting next to a doctor and somebody else is evaluating you, or somebody's beaming in to see you while you're in a hospital. But otherwise, you're meeting face to face, they're evaluating you. They know that you're a 17-year-old, not a 54-year-old who's saying, I've got chronic pain, and getting enough medications that you, unfortunately, it becomes a lethal amount for you. During COVID, they made that more flexible to say, this is a medication, we've got, risk of disease transmission of COVID. We're going to open this up to if a medical provider can evaluate you by telehealth, or even if they can evaluate you well enough by phone to say, yes, starting you on this medicine right now is a better option than the option you have in front of you. They've allowed that. There was a lot of fight about what was going to happen post-COVID. I think there was when the DEA proposed the regulations, there were 48,000 replies, which was one of the largest sets of replies the DEA has ever received on what to do about what should the rules be going forward. And they just came out saying, basically, you can do this for up to 6 months, but then we want the person either physically evaluated or a full telemedicine evaluation, and you have to have X, Y, and Z to make that work. So I think those are the 2 policy things that have
Both working in your favor.
Yeah, I mean, I think there's good and bad in everything. I think on one hand, for a state like Vermont, and just in context, we provide more medications for opioid use disorder than any state in the United States, and probably any country in the world with the possible exception of France. So we went all in on medicine because that for us was to speak to the community standard of care. That is what keeps people alive. So we went hard and fast on it and said, we can piece out everything else, but unfortunately, people who are deceased don't recover. So this is what we need to do to get people safe. So I think because we have so many providers, the need for somebody potentially to go 6 months without being seen by a medical provider probably isn't as important here. If you're in a remote area of the country where there might be one community doctor in some of these frontier states, or even some of the states that just haven't embraced medicine, you're having, internet companies seeing people across the country because it's the only access to care they have.
Thank you.
Yes.
Oh, well,
I don't know if I think this might be somewhat separate from the DOC side of things.
Sure.
I know that in Bennington, they've discussed building a methadone clinic.
Yeah.
Would that tie in with DOC's work, and what's the data look like on that? Because I think there's a lot of community perception about that that's just kind of all over the place. You're hearing positives, negatives, a lot more of the negative, but I'm just curious because we say it works well, but if it really works well, I feel like that would have translated to people in Bennington by now.
Yeah. So let me take that one step back and just say, let me kind of define what a hub is versus what a spoke is, because I think it'll speak to your question also about folks in corrections and your question about if they're not a hub, how do they have medicine in it? So a hub is basically a self-contained healthcare clinic that has to be both the medical provider and the pharmacy. So they are both the dispenser of the medicine as well as the medical provider. It's all under one roof. And they are licensed by the DEA as what's called a narcotics treatment program. We have 7 of them currently in the state of Vermont. We have one under construction in Bennington. For folks currently in Bennington, we contract with a program in North Adams, Massachusetts. So what happens with corrections for folks who are on methadone, folks who need methadone? If you think about it, it works very much like it would any other pharmacy situation. So if I'm in Chittenden County and I'm going to the Howard Center Chittenden Clinic, but I am picked up and I am incarcerated in Newport, we have interoperational agreements, not only all of the hubs with WellPath and the Department of Corrections to get medication in, but then we also have agreements across all of the clinics. So if Dr. Brooklyn at the Chittenden Clinic wants to get medication to me at Newport, he calls Dr. Kelly at the Newport office and orders that they become the pharmacy of record, so that the Newport corrections folks just go pick up the take-home doses in Newport rather than trying to drive to Burlington to where I am, where my doctor is. So we have this operational agreement that wherever the closest clinic is the provider of the medication to make this easy for corrections. And while we dispense it, it's much like a pharmacy, right? So the pharmacy dispenses the medicine, you can take it home. For corrections, they get to take it home now, and they store it under safe storage, and their nurse dispenses it. But we have kind of safeguards of checks and balances in who picks up the medicine, when does it get logged in with the nurse. So we have a chain of custody agreement that shows everything from who's the nurse that dispensed it at the clinic, to who were the security folks who picked it up, to who was the nurse that logged it at the facility, and then the days that it was dispensed. Which is how we tried to do this, to make sure that, because it is so regulatorily burdensome, that we really tried to make sure that we had a functional system so that folks can get medication around with the least amount of transportation possible. We try to limit the inmates' need for transportation, because it does present a safety risk when you've got to bring somebody outside the walls and you may have to have 2 guards. And depending on where they are, they may have a history there, and it may not be a good history in the moment. So we've tried to limit that to basically new evaluations. We need to see you for a new evaluation. We want to make sure we're going to come up with the medical plan with you. We're going to discuss how your dosing is going to work. But then we're able to give the medicine to the security guards who are able to do the in and out. And then the WellPath nurses and medical providers give back the feedback around how things are going back to the provider at the hub.
So Will, your question was you have a methadone clinic
Under construction.
under construction.
yes.
Would that be a hub?
Yes, so that will be a hub. It'll actually, it's through the BART folks, so Bay Area Research and Treatment. They have the clinics currently in Newport, St. Jay, Berlin, and St. Albans. So it's a provider that's used to working with us. It's a provider that's part of the hub system. It's a provider that's been with us in building the hub system since day one.
Pays to build this hub.
It's an opioid settlement fund, isn't it?
So we did, I believe we gave some startup costs to out of opioid settlement funds. Otherwise, it will be based upon billing. So they'll be billing for Medicaid services, and then we receive what's called a federal block grant. So we get money that really is intended for those folks who are uninsured or underinsured. And we give that as well to all of our providers to augment the costs of folks who just are either have catastrophic deductibles so that they can receive care, or folks who are without insurance at any given time.
So I translate that as private practice. You have a doctor who's willing to invest. They have the credentials, therefore you can have a hub.
Yep.
Financially
Yeah.
helping them do that.
And what we do is it all runs through and it runs through the certificate of need. So everything has to go through the CON process. Basically, the difference, a spoke practice really is any medical provider who wants to set up shop. A hub is, to some extent, we're inviting you in, we're soliciting you because we have a need. And so we're going to put all of the structures in place with you.
And encourage finances.
But this is the spoke connected to the hub?
Yes. So in the hub and spoke system, and this will actually speak a little bit to your question about transitions of medication. So in the hubs, they are the only clinics that can provide methadone ongoing. They also do buprenorphine and they also do naltrexone, and I'll give a little spiel about each of them afterwards. But what happens is the way we built this system intentionally was to, again, replicate every other healthcare system. If you think about somebody who's on buprenorphine or naltrexone or any other healthcare medicine, we get the majority of our care, if we're fairly stable, at primary care. So for folks who are fairly stable, we have them seen in primary care practices. That is the largest number of prescribers that we have in the state of Vermont is primary care. They tend to take fairly stable, again, not 100% stable, but fairly stable people, and they can manage their other healthcare conditions at the same time. Much like any other healthcare concern, if all of a sudden my GP is handling my cardiac meds, but all of a sudden I start having a flare up of cardiac problems, they send me to a cardiologist. We have a subset of specialists that we call kind of super spokes, who then they can refer up to say, this person needs to be managed by a specialist. They're restabilized, and when they're stabilized, they can come back to me. But right now, the acuity of their needs is too high for me to handle. And then again, much the next step up, we have the hubs where if we're looking at somebody who can't manage their medications, they're not taking their medications as prescribed, they may have lost their housing and they don't have a safe place to store it. Or we do have some folks who, again, during the process of getting better, behaviors change at different times. They may try injecting some of these medications, right? Which again, they have a history of injection drug use. I'm going to try to do that because I haven't solved that problem yet. So we're able to send those folks to the hubs where it's a daily structure and they receive their medicine. They start receiving medicine as they start to stabilize. So their take-home medicines don't start until we can see that they're stabilizing. And otherwise, they're being seen every day by a nurse for a nurse check 6 days a week to say, are you safe? Are you okay? Are you at risk? Let's evaluate your health. So we have this kind of bi-directional relationship as we would anywhere else to say, what's your medical need? And who's the right provider to take care of your medical need? Up through if somebody needs to go to residential treatment or if folks need to be in the hospital. What's your need? And we will refer you up and down the track as you need fit. And that is how I see corrections. Folks come into corrections. We kind of restabilize the criminal behaviors and they're coming back out. There are times that during corrections you say, wow, this person's probably their behaviors. Doctor, you didn't recognize some of the behaviors. This person's going to need a more intensive level of care. Let's, instead of coming back to you, we're going to set them up with one of these specialists. And then as they stabilize and as they get reacclimated to the community and their lives change, they'll come back to you.
Thoughts, questions? Who would think we'd get into something like this when you came into corrections and institutions?
And corrections, I mean, if you think about it, corrections is always going to have a significant number of folks. So whether it's the individual who's in the correctional system because the substance use, the having to pay for the substance use, the obtaining the substances is expensive. And it's I don't want to call it petty crimes, but they tend to be the property crimes. They tend to be the drivers of how do I get money?
Retail theft. Yep.
And the flip side is when you think about folks with opioid use disorder, about half of folks with opioid use disorder have a history of antisocial personality disorder. They've had problems with following rights and norms and rights of others for long periods of time. So those folks already had, if not correctional involvement, they may have had juvenile justice involvement, or they've had a trajectory that is going to be touching the criminal justice system in all likelihood. And then you add the substances at the same time, which just then logically says that individuals involved with the Department of Corrections are going to have a higher rate of interaction with this substance and need these medications at a higher rate than the general public.
You asked for thoughts.
Mhm.
We keep coming back to if we could eliminate selling drugs for profit, the state of Vermont would be so much better off. Every aspect.
Get a deal with the market. There's
Yeah.
a market here.
There is supply and demand, no question.
It's a market of our population that's being preyed upon because it's a market.
Yes. Yep.
Cut off the supply, though, there will be less demand because, once again, personal experience. One tried it because it looked fun. One was stressed, thought it would help.
That's right.
And if it wasn't available, neither one of them would have done it.
Yes. Yeah. And that is, there's no question, availability is wide. We look around and again, like I said, we treat more people per capita than any place we can find. And our best estimate is somewhere in the 50% to 2/3. That still leaves somewhere between 50%, a third to 50% of people who are not actively seeking treatment, who are at various stages in this disease development, who are still out doing what they're doing. And some of them are on an upward trajectory. Some folks are on a maintenance trajectory, and some are, unfortunately, every use is a risk. Yes, sir.
How many people, so you said there's 7 hubs, so that clearly means there's a lot of people that are using them. How many people are in this system? If we only have about 1,400 people that are incarcerated in this
So if you think of state, or do you want to think about the correctional system in general? Or do you want to think about statewide? How many people do we estimate on medication?
I think both. So let's,
Okay.
I'd be curious.
So statewide, we estimate we are somewhere on any given day between 9,200 and 9,500 people
That's
who are receiving medications for opioid use disorder.
And that might be,
And that might be half to 2/3, yes. When you think of the correctional centers, on any given day, we're probably somewhere between 650 and 800.
Can you repeat that again.
650 to 800 people.
Out of our 1,400 plus.
Yes. Yep. And a lot of that is detainees, right? So if you think about it, opioid use disorder, when they do what's called the National Survey for Drug Use and Health, which is supposed to be the biggest survey in the country, blah, blah, they estimate that opioid use disorder affects somewhere between a 1.5% and 2% of the country. We know, so we always talk about underreporting, and I always kind of speculate, like, what do you mean underreporting? Are you sure? I can look at underreporting in this one and say, we treat over 2% of the Vermont population with medications, and we know that we have not touched everybody who has that need. If the numbers that national numbers were actually applied to Vermont, and again, Vermont's not separate than many other states, we would have eradicated this illness. And yet we know we haven't. And in COVID, we saw large spikes in overdose fatalities.
Thank you.
I'm gonna form this as I'm thinking it, so bear with me. So these numbers are alarming, right? And especially in the state, the size of Vermont, right? That's a noticeable percentage of our population. In part, right, the numbers are high because we know, because we're so well set up to provide medication and to track medication. So we have probably a pretty good and perhaps even a more accurate understanding of what percentage of our population is being treated. Is there any forecasting on a national level about how this pandemic of opioid use disorder is going to or likely to proceed? And are we ahead on that curve? Meaning we're closer to that light at the end of the tunnel.
Yeah.
Do you know my question?
I do. I understand it. I don't think there's any great forecasting, unfortunately. Historically, drug trends have changed about every 17 years. That's when we look back on history. This one has lasted longer than 17 years. What we keep getting is the new age of bigger, better, stronger, and faster medications rather than the change of substance. From the standpoint of forecasting of where do we stand, I think that the rest of the country is still trying to figure out how to emulate where we are.
Yeah.
There are only 2 states in the United States that, and not just the state believes this, but where Kaiser Foundation has done a review of kind of capacity. And they looked at it and said, if every single person that used narcotics needed treatment and came out of the woods today, what states could handle that? And there were only 2, ourselves and Maine.
Well, that's something to be proud of.
Yeah. I mean, what we have to figure out, and at our office, what we are continually trying to figure out is how do you touch the folks who aren't ready to be touched, don't want to be touched, and that we don't know about. So we look at how do you hit the high risk situations. So high risk situation 1, we knew coming out of Department of Corrections is a high risk situation. Let's make sure that Department of Corrections is part of the system built into this. We had to build the original community system, so we had capacity, but then Department of Corrections, folks coming out dying at 129 times the general population in the first 2 weeks after release. You are high risk. How do we help you? Emergency departments, even if you're not coming in for a fatal overdose or a non-fatal overdose, if you're coming in for anything else, you're still at high risk medically. we can evaluate you, and if opioid use is part of this, let's treat you. If you're coming in withdrawal, let's treat you. And then we built pathways, just like we did with corrections, that basically, here's how this person's going to flow, and everybody knows that up front. So if I walked into Central Vermont Medical Center tomorrow and said, I have opioid use disorder and I was in withdrawal, they would initiate my medication. I would be seen by a recovery coach who would be kind of part of the walking me through the process. And I would have an appointment scheduled before I walked out the door, and all the documentation that needed to go would be sent to that provider. So they'd be expecting me. And everybody on the team would know the time and appointment before I ever walked out of the ER door. We've built those systems to try to catch those folks that we haven't been able to catch otherwise.
Editorial comment.
Yes.
I'm not saying what we're doing is wrong.
No.
Clear? But because we have such a good system helping those who need, we are bearing huge costs in the state of Vermont that is heading us towards insolvency.
Yeah.
Because we are providing all the care for so many people. It's analogous in my mind to the United States cleans up all their air, but China's pumping it out at 10 times the amount. We're not fixing the problem. We're just making it easier for everybody else to get by.
Yeah, we're dealing with the demand side. We're dealing with it after the fact. And the cost offsets, where we look at it for the treatment, if somebody goes into a hub for a year and they receive methadone for a year plus coordinated services. So, because again, we want to make sure primary care knows, we want to make sure probation and parole. So we want to not have folks just, everything shouldn't happen under one roof. We want to make sure everybody's on the same page, both the good and the bad. We want to make sure it's on the same page. We treat those folks for just over $6,000 a year. We had, if you look at, there was some recent numbers that came out of COVID. I want to believe it was 2023 of folks who had heart and skin related infections from injection drug use. So what's called infective endocarditis, which is growing bacteria on the heart, or cellulitis. I think there were 99 Medicaid beneficiaries, I believe, that received treatment in 2023. The average cost of those treatments can range anywhere from $120,000 per person to $1 million. So if we can treat those folks, if we can figure out how to get them at $6,000, we're saving a heart valve replacement about $1 million. And so we've done outreach. We just gave providers outreach money because what we looked at was the data that said, the last round of social autopsy data, we looked at it and said almost 70% of the people who experienced a lethal overdose, we can't find any evidence that they were ever diagnosed with anything related to opioids by their primary care. There is no notation in there in any medical record that we could find anywhere. We don't know these people exist. So what are we doing? Let's give our providers money to start engaging them and going out and finding them. If you won't come to the mountain, if Moses won't come to the mountain, we got to send the mountain to Moses. And how do we do that? And so we're continually trying to figure out, as we get more information, what do we do next?
Tony, I think it's really important to compare those healthcare costs, the 6,000 versus if you're not treating it, what it develops into, and then what the real cost is. I think it's also important to factor in the criminal justice system cost.
Yes.
If you don't treat it, you're putting pressure on your local law enforcement. You're putting pressure on your local court system and putting pressure on your local correction system, which impacts your state budget.
Infectious diseases. I mean, there's a whole host of things that are reduced by getting folks care. Again, it's never one for one, but it's cost, both human suffering, but also cost reductions by doing them. And so that is really what we continue to try to do, is to say,
Yeah.
And to some extent, I'm sure, from your perspective, sir, and sometimes from mine, it feels like whack-a-mole. Like, what do we got to do next? Because we want folks to be healthy, and we're just building a system going, okay, we've got this, and now we've got this, and what do we need to keep adding? Or adjusting.
Because the patient's bleeding, but we've got to figure out how to stop inflicting the cuts.
Mhm.
That's what we got to get to the root cause. Now, we can't do that. That's the frustration.
Yes, sir.
Just quick math, you know.
Sure.
Don't do math in public.
I will. You know, by what you were saying, if it's 9,500 folks, right?
Yep.
And they are costing $6,000 a year, that's about 57 million a year, which seems like a lot of money. However, if those 9,500 people are in jail, times like, if they are, you know, then that's $665 million a year.
Yeah.
So to me, it seems like that $6,000 is a great investment.
So I think I grew up as a poor kid in the Northeast Kingdom. I'm from Newport. My friends will look at me and say, and they will grill me, literally just, what are you doing that I can assure me as a taxpayer that what you're doing is the right thing? And I think we try very hard to say, we want to do the right thing for healthcare. We are trying to be the best stewards of resources we can, because we really do want people healthy, but we also recognize that folks have to have employment. Folks have to have all those things that we want them to have. And breaking the financial banks, we want to make sure that we give them the best we can.
I have a couple more questions.
What's more,
James and then Will.
more of a statement? So bringing up Kevin's point, just really for new people to understand here. This is in fact like basically can build as Band-Aid. It's dealing with symptoms. Your point about dealing with supply, et cetera, those are valid and everything. The city should be looking at it as much more holistic. But what I wanted to share with especially new members is that we won't have control in this room. We should talk about it, but we won't have control. But down the hallway, for example, judiciary can have control over that aspect. Maybe there's other things that deal with health at a deeper, that will be upstairs in health committee. So just to understand that, yes, we're dealing with this, and it's the only thing that's kind of in our purview, but the other things should be addressed, and maybe to some people's degrees, it's not as much as we'd like it. But that's where we've got to keep in contact with all the other members and other committees to work with them to do that holistic approach.
Amen.
Well,
I think too, you were talking about it more from the corrections side. I don't think all these people necessarily be in a correction setting if they weren't receiving this. But I guess out of this population, because you have, you said the 9,500 that are out in communities that are receiving this. I'm curious how many of them have stable employment, what their, I don't know, the data around the income they make, things like that, because I feel like that would be more at jeopardy if they weren't receiving this.
Sure.
Mindset.
So in the spoke system, in the general medical system, we don't monitor that because we didn't want to set anybody apart from, I'm going into my doctor and are they giving me Prozac, or are they giving me a diabetic medication, or are they giving me Bupe? We do monitor that in the hub system. And the hub system are the folks who either on methadone or by intent have more structural problems. We wanted them to be more tightly monitored. Within the first year, it tends to be about 2/3 of folks have some kind of, they're either employed or they were folks who never had received disability, but truly were disability eligible. But we get to about 2/3 within the first year of folks who you can say went from not doing much other because of the effects of their substance use to having some kind of meaningful part of their lives, whether that's full-time employment, part-time employment, or,
Thank you.
so I hope this has been helpful for folks. I know,
Can I answer there was one outstanding question you'd asked about transferring medicines from buprenorphine, methadone.
Yes.
So just a very quick, like medicine for non-medical people, because I'm not a medical person. So there are three basic FDA medications. Naltrexone, and I give just an analogy for folks. So think of naltrexone as I'm putting gum in a lock, right? It doesn't activate your receptor sites. It's not necessarily going to make you feel any better. It is just going to stop any opiate you take from trying to get in the door. So it works purely as a blockade system. Folks have to be 7 to 10 days abstinent from opiates before they can take it. And again, because it doesn't activate the receptor sites, those folks will continue to experience withdrawal symptoms and longer term withdrawal symptoms because it's not re-energizing them. So it is effective, but not widely used. I think we probably actually use it more often for folks with alcohol use disorder, where it has some real effectiveness as well. But I would say if I think of the numbers in the state, it's probably more likely to be used for alcohol than it is for opioids. But for some folks, they do really well with it to prevent relapse. Buprenorphine is what's called a partial agonist. So I think of it like a U-Haul truck. If you ever drive a U-Haul truck, it's got a governor. You can mat it and it's still not going over 60 miles an hour. Right? That's how buprenorphine works. Buprenorphine at lower doses is more potent and it hits a governor somewhere around 24 milligrams. So even if you keep taking more and more, it doesn't really have any change in effect. That's also why it has a better side effect and safety profile, because you're less likely to have an overdose because you're not getting respiratory suppression because it stops working at a certain point where it doesn't really give you any more effect. And the other side part of that is it tightly binds to the opiate system. So if folks take opioids and then take buprenorphine too quickly afterwards, it walks in, and for anybody who's a baseball fan, it looks like Pete Rose sliding into home plate, and it'll knock the stuff right off the receptor sites and send people into imminent withdrawal. Like, watch your shoes in the first 3 or 4 minutes because people will likely be vomiting on you if you've given them buprenorphine too soon, which is many people then refuse to take buprenorphine afterwards because they see it as a negative medication, right? Methadone is your standard car. The more you put your foot on the gas, the faster it's going to go, which allows you then to be able to treat those folks who have higher use patterns. And so for folks who are, injecting fentanyl, for folks who are, using higher rates, we actually can go up there. It's a fairly easy transition if somebody's taking buprenorphine to move them onto methadone. So if I go into the correctional center and I'm on buprenorphine and I get some swelling in my legs or I just don't feel right, it just isn't working for me, it's fairly easy for us to switch them over to methadone. If the person is on methadone, switching them over to buprenorphine, we have to taper them all the way down to like 30 milligrams or less, because otherwise, if we give them buprenorphine and they got methadone in their system, we just made a mill. So it's a harder conversion.
That's super useful. Thanks.
So I hope this has been helpful to folks.
Very good.
Because we do have some bills that are coming in. And also the DOC will be coming in with
Oh my
some
goodness.
requests dealing with the MOUD program within corrections. And I think in order to understand any proposed changes to it, you have to understand what's in place right now and how it works or how it doesn't work. So that's why we spent so much time on this, so that we as a committee have that base of knowledge. So then we can understand the proposed changes. So Tony, thank you. I think we'll probably have you back.
Thank you. It was my pleasure, and it's always my pleasure to see you. You may give me credit for these things, but between yourself and Butch and Annie Ramniciano, I learned more than I ever thought I could have learned about the legislative process, and I think I received far more out of this than what I offered.
Well, it worked both ways. It really worked well.
Thank you, sir.
Thank you. Let's take a quick 5-minute break and then come back.